Okay, well, welcome to another MEDCRAM lecture. We're going to continue talking about the things that we do in a systematic way to review a chest x-ray. And so the next thing is we've done A and we've done B, and now we're going to move on to C. So for C, we're looking at the cardiac silhouette. So what I'm outlining right here is the heart. If it's more toward the right, you want to think of situs inversus. Here you can see it's more towards the left. You also want to take a look at this distance here and make sure, especially on a PA film, that it's half the distance from the entire thoracic cage. If it's greater than half the distance, you might consider congestive heart failure or cardiomegaly. So these heart borders are very important because if you see enlargement, you can tell what part of the heart you're looking at. This one right here is the right atrium. Okay. This one over here is actually the left ventricle. The left atrium is right up here. At the top here, we have the aorta, specifically the aortic arch coming down. And then right in about this area here, we have the pulmonary. So this is the pulmonary artery, and this here is the aorta. And then what's left here in this area is the left atrium, kind of in this area as we've talked about. That's the left atrium. Okay, so imagine if you are a skier and you're skiing down the slaloms, the first slalom that you're going to hit is the aorta, then the pulmonary artery, then the left atrium, and then finally the left ventricle going all the way down. Now, because of shadows, and we talked about before, if there is water density material in something that is normally air dense, you're going to lose that line. That's called the silhouette sign. So let's clear the screen and look specifically at this area here. This is the right heart border. Now, that right heart border is abutting the portion of the lung that is the right middle lobe. So if we lose this, if it becomes hazy here and we don't see any line, then what we know is that we've got a pneumonia in the right middle lobe. Okay? Now, similarly, if we have loss of this line, so if it just becomes a hazy mess and you can no longer see that line, this portion of the lung here that abuts the left heart border is the lingula, which is technically part of the left upper lobe. It's not its own lobe, it's just the lingula. But that tells you where the pneumonia is. So right heart border, right middle lobe pneumonia. Left heart border, lingula. Next thing we want to do is look at D, moving on to D. D stands for diaphragm, and so you can clearly see here is the right hemidiaphragm, and it's usually a little bit higher than the left hemidiaphragm. Both should be sharp, have sharp angles. This is the costophrenic angle right here. Costo meaning ribs, phrenic meaning phrenic nerve, which innervates the diaphragm. So these should be smooth and sharp. As we mentioned, the right hemidiaphragm should be higher than the left hemidiaphragm. And that's because of the liver and versus the stomach on either of those sides. The highest point on the right here should be right in the middle, and the highest point on the left should be slightly lateral to the mid-lung, so kind of in this area here. But it's not a hard and fast rule. Generally speaking, this should be smooth. Now, if there is loss of this, the same principle applies. We now have two things basically interacting with each other, abutting each other with the same density. And if it's in this area, this is going to be a right lower lobe pneumonia. And if it's on this side, this is going to be a left lower lobe pneumonia. So you can already tell just by looking at a chest x-ray, if you lose this line here, that's going to be a right middle lobe. If you lose this line here, that is going to be a right lower lobe. If you lose this line here, the left heart border, that's going to be a lingular pneumonia. If you lose this line here, that's going to be a left lower lobe pneumonia. Now, one of the things that's pretty important when you look at an upright film is the looking for something called free air. Now, you might pick this up here you can see some air bubbles, but they're clearly inside the stomach. What you want to look for when you're looking for free air is you want to look right underneath here, because the hemidiaphragm is pretty small, thin that is. And if you see an area of lucency, of air density like this, maybe it won't be this black, or you see something similar over here on this side, that could mean you have free air. It might look something more like this. Okay? If you see what's called free air under the diaphragm, that's a sign that you've got a bowel perforation. That's a surgical emergency in most cases, and you'd want to get an acute abdominal series and get surgical consultation. Sometimes you can see this right after the patient has gone to surgery because there's still air down there and it might collect. So just be aware that if you see free air under the diaphragm, that's where you're going to see it. It's usually going to be in an upright film, and you've got to watch carefully for it. The other thing that you might see that's not as dangerous, but nevertheless there, is you might lose this sharpness of the costophrenic angle, and it might look like this. This is called the meniscus sign, and you need at least about 300 cc's of fluid in the pleural space to lose that very sharp angle. Okay, so that would be a little bit of a pleural effusion. Maybe this would be a lot of a pleural effusion. And this would be bilateral pleural effusions that you might see. Meniscus sign means it's tracking up the side. Tracking up the side, like that. Okay, so that would be a sign of a pleural effusion. Okay, the next thing we're going to do is move on to ENF, which is equal lung fields. So what we're doing is we're looking at the lung fields here at the top and the bottom, everything here that's black. And we're looking at it from a number of different standpoints. The first thing that you'd want to do, and I can't do it here so well, but you really, if you can, zoom in and look very carefully all the way around the edge of this lung. And what you're looking for is to make sure that these, these little spider web type of looking things, that they're all, these are lung markings, we call them, making sure that they're going out to the periphery all the way to the edge. If there's a pneumothorax, what you're going to see is you're going to see a pleural line back away from the edge like this, beyond which you will see no pleural markings. And that's a sign of a pneumothorax. Sometimes the pneumothorax can be very obvious, and we'll go through some examples of this. But you want to look on both sides, and you really do need to zoom in very carefully. This would be a small pneumothorax. A large pneumothorax, of course, would be something like this, where there is absolutely no lung markings distal to it. Okay, so that's the first thing you want to do when you're looking at E and F. The other thing you may want to do is just look, generally speaking, at the vasculature on the right versus the left and see if there's a difference between the two. There's a condition called Westermarck sign, where if there's a pulmonary embolism on one side, all of the blood is going to go over to the other side because it can't get through. And that's going to make one lung look very hyperemic, and this lung look very quiescent, like there's not a lot. This is the side that actually looks normal from a standpoint of not a lot of vascularity, when in fact, if this is a pulmonary embolism and this is Westermarck sign, this is the side that has the problem. In this case, this is a normal chest x-ray, and as you can see, both sides are pretty normal. They're both about the same. The next thing you want to look for is the vascular markings, and you can kind of make them out here in this picture. You can kind of see here these little markings coming out here, coming down here, coming down here. So those markings are the vasculature, and then they get so small that you can't see them. One of the things that you'll notice in someone like, for instance, with congestive heart failure is the plumpness of these vessels become so large and so engorged that instead of gravity making the ones lower down look bigger, as you can see here, the ones definitely lower down are bigger, you start to see the ones up top getting bigger, and you can make them out. And there's a specific term for that. It's called cephalization. In other words, you're taking the stuff that's at the bottom and you're bringing it towards the front. That's cephalization. So those are the pulmonary vascular markings, and you can look for that and see. If you see cephalization, you want to think of cardiopulmonary congestion or congestive heart failure or pulmonary vascular congestion. Another thing that you might see in congestive heart failure are something called curly B lines, which are about 1 to 2 centimeter horizontal lines coming in from the side. Might be able to see them here when we show you some x-rays that have congestive heart failure in it. But basically little lines that come in from the edge. If you see those, that's fluid in the lung that's causing these curly B lines, and that's consistent with cardiac enlargement and congestive heart failure. Another thing that you might be able to see are something called air bronchograms. Now, the biggest and easiest air bronchogram is something that we saw at the very beginning, and that's the trachea. That's where you have a structure that is filled with air that appears lucent in the background of something that is water solid. That's the same thing can happen here in the lungs. If you've got a pneumonia and there's a bronchus that's going through the pneumonia, you'll actually see an outline of those bronchus in the middle of a pneumonia, and that's an air bronchogram. That tells you that there is infection or pneumonia or water density in the lungs, but not in the airways. And that's important to know because when you see an air bronchogram, that tells you that air is actually getting to that area, that it's not an obstruction. So I think that completes our analysis of the normal chest x-ray. Join us for another lecture where we can look at some abnormalities and point those out to you. Thanks for joining us.